Hi, my name is Rachel Snyder, and today I'm going to talk about antiviral therapy focusing on HIV. When talking about human infection, viruses are very different than bacteria. Antibiotics and antibiotic resistance are increasingly popular topics covered in medical journals and the news, but it seems that there isn't near as much talk about the treatment of viruses. This has a lot to do with how different viruses are from one another. Plant and animal cells share many characteristics with cells of other plants and animals. Bacteria share many characteristics with other bacteria. Metabolic processes in these groups are highly conserved. Similar genes can be seen across a variety of different organisms. With viruses, they tend to lack these overall similarities. This has inhibited the production of a broad-spectrum antiviral, whereas there are several antibiotics that can take care of many species of bacteria. Since there are so many different types of viral infections, I decided to focus on a major one that has been extensively studied. In 2016 alone, 40,000 Americans were diagnosed with human immunodeficiency virus, or HIV. It is certainly more prevalent in third world countries, but it does happen here. HIV works by attacking CD4 cells, which are quite important regarding immune response. There is no cure for HIV, and without treatment it will progress into acquired immunodeficiency syndrome, or AIDS. Treatment can help control the virus, and an infected person can live a relatively normal life if they begin treatment in the beginning stages of infection. HIV is a retrovirus and is known for its high levels of mutation, which is another reason that prevention and cure have not yet been achieved. The treatment that is commonly used for HIV is ART, or antiretroviral therapy. ART prevents HIV from multiplying and in turn reduces the viral load in the body. This also reduces the risk of HIV transmission. HIV can gain resistance to the specific drugs used to control it. Not taking the medicine as directed can allow for more growth and a greater likelihood for mutations that lead to resistance. This requires the medication to be readjusted. There are 7 classes of drugs used. These include NNRTIs, NRTIs, PIs, fusion inhibitors, CCR5 antagonists, INTIs, and post-attachment inhibitors. Generally, a regimen includes at least 3 drugs from at least 2 different classes. There has been debate as to when ART needs to be given to patients. Numbers such as less than or equal to 500, 450, and 350 CD4 cells per millimeter cubed were debated, but the results concluded that all HIV-positive adults should be treated regardless of their CD4 cell count. ART has also been shown to reduce the risk of tuberculosis and invasive bacterial diseases. Early treatment can also prevent HIV from becoming AIDS. The infection is considered to be AIDS when the CD4 cell count is less than 200. By way of comparison, a non-infected individual has a range from 500 to 1,500 cells per millimeter cubed. The downside is that the risk of cardiovascular disease is higher in HIV-infected patients, and ART can increase these risks. ART can also increase the risk of metabolic abnormalities, which include things such as hypertension and diabetes. Since HIV infects the immune system, certain cancers such as sarcomas, lymphomas, and others are more common. ART can increase these risks because it increases the lifespan of the individual, and the different classes of drugs have different side effects, which we'll talk about in a second. So how does ART work? As discussed earlier, NNRTIs are non-nucleoside reverse transcriptase inhibitors, and NRTIs are nucleoside reverse transcriptase inhibitors, are 2 of the drug classes used in ART. As indicated by their name, these inhibit reverse transcriptase necessary for the HIV to multiply since it is a retrovirus. Protease inhibitors, or PIs, also work once HIV has already entered the cell. NNRTIs can cause a rash and cause Stevens-Johnson syndrome. NRTIs can cause lactic acidosis and body fat redistribution. PIs are associated with metabolic abnormalities like insulin resistance and body fat redistribution. They also have many interactions with other drugs. Fusion inhibitors, entry inhibitors, and post-attachment inhibitors keep HIV from entering the cell. HIV must bind to the protein GP120 on the surface of the cell. This will cause a conformational change in that receptor. This causes GP41 to bind to a co-receptor, which will allow for HIV to enter the cell. This drug class inhibits one or more of these processes. Fusion inhibitors can also cause injection site reaction and increase the frequency of the patients to get pneumonia. CCR5 receptor antagonists are another type of receptor antagonists that prevent HIV from binding to the CCR5 receptor. They are transmembrane, G-protein coupled receptors that are expressed on many types of cells, such as T cells and macrophages. HIV-1 uses these to enter into the cell. CCR5 receptor antagonists cause diarrhea, nausea, upper respiratory tract infections, joint and muscle pain, fatigue, headaches, and dizziness. Integrase strand transfer inhibitors, or INSTIs, block an enzyme called integrase, which inserts the viral DNA into the host genome. This prevents HIV from being able to replicate. World Health Organization publishes updates on HIV and gives its recommendations on a pretty regular basis. One of their latest updates include the addition of pre-exposure prophylaxis in uninfected individuals who are at a high risk of getting the disease. These can be given orally or topically as a gel. In clinical trials, these have been shown to reduce the risk drastically when added to other prevention measures. The difficult part is making these drugs safe and effective for use outside of clinical settings. They also give the recommendations when it comes to children who are exposed to HIV. The World Health Organization used to recommend that infants who test positive at all for HIV should begin ART as soon as diagnosed, and then the diagnosis should be confirmed with a second test after to check the accuracy. Since then, the recommendation has changed to say that due to the risk of ARTS and the side effects and all the stuff like that, infants and young children should have a confirmed diagnosis before they begin treatment. This is contrary to what we talked about with adults who at any CD4 cell count should begin treatment. Post-exposure prophylaxis is another new thing that they were talking about that can be given within 3 days if you think you were exposed to HIV, and that it should reduce the risk of the individual contracting the virus. Overall, HIV is a disease that has impacted the lives of countless people. Although there is no cure, ART has provided a way for those infected to live as close to a normal life as possible. And here are my sources. Thank you.